Good evening, everyone. So I'll be speaking about trauma surgery by resident, a must. Nil financial interest. Tell me I forget. Teach me I may remember. Involve me and I learn. So why in residency? So it is a new skill and these are fresh beginners who are joining and aren't they first on call? The moment the first years enter, I remember the second years to tell that you have to go and see the emergency patient first, whether it be in the OPD or the night calls. So why not introduce them to the what is going to happen to such patients? And obviously, they'll be under supervision. So what will be the prerequisite? Definitely, I'm not expecting that first day, first year surgeon, first year student is going to perform a surgery. He needs to know the theory. He has to have wet lab practice, has to know the knowledge about suture material, how to take the knots. It is one stitch at a time process. So what all to know before jumping? Knowledge and prior experience in tissue handling. The resident should be taught how to respect the tissue. Where to start? He has to know about the anatomy, the anatomical integrity, whether the patient whether it has to be started from the limbus or the sclera or the cornea. About topographic closures, where to take the bites, which bites are closer, which are smaller, which are longer, what to touch and what not, when to cut the iris, when to touch the vitreous, where to stop, which is very important. What about the complications when you do it wrongly? And what is the prognosis of every case? And why not? Aren't they supposed to know about the assessment, the approach, the counseling process, the basic of trauma surgery? We are not going to limit them only with the classification of ocular trauma scores. And if not, primary repair is the most crucial step. It causes a delay in triaging. An underconfident surgeon during the first independent surgery. It is not that first day senior residency, the student is suddenly going to know how to do a proper closure, especially when the junior is standing in the sideboard next to him. So what is not expected? Unsupervised surgery. They always have to be under the supervision. Complicated or high-risk cases, extensive wound loss cases, IOFP, tissue requirement, multiple surgeries at the same setting. So I would like to conclude, these students are getting exposed to trauma cases in everyday practice. Theory, just textbook knowledge is not sufficient without the practical approach. And we should incorporate more hands-on training, lab training in our curriculum. They should know the case-specific approach, and obviously it has to be practiced under supervision. These are the students who are going to become the teachers of tomorrow. They are the budding cornea specialists, retina surgeons of tomorrow. And last but not the least, there are no shortcuts. There might be shortcut to success, but there is no shortcut to the skill. Thank you.